Um, some of it is, because the ER, as you said, it's very fast paced. It's very quick. It can be very task oriented as well. So what is the patient expecting in between these tasks that are showing due in the EHR? And I feel like that's something that I really got from working on the floor. However, my first orientation to the ER was about 3 days long, and it was, kind of basically like, oh, that's where the code card is. Any questions? So it wasn't super supportive. There wasn't a whole lot of like education available to me. There wasn't really this culture of please ask questions. If you don't remember the DKA protocol, here's where you can look. Or this person is always really helpful when it comes to putting in NG tubes or Foley's, which is what I'm seeing a lot of the residents get. They're getting a lot of those resources right away. And a good portion of them stay in the ER. They don't always stay in the ER that they start in because they're kind of bound to this 2-year contract. And a lot of times they're ready to kind of get out and go do something different. But a lot of them stay. And I work with, nurses that have been nurses for 5-10 years that started with a residency and have a really solid foundation. So I think that if that's something that you're interested in, it's definitely worth pursuing and talking to the people that are doing the residencies and interviewing. But if you don't get one, definitely don't be discouraged. Don't lose hope. Any skills that you learn will be helpful to you in the ER.
And actually, can I follow up on that too? Since you talk about the culture, and she said like, oh, there's a code card and there's that. So I kind of want to ask you about that too, because like the culture in the ED, people like it's all tough, everything is cutthroat over there, and then how ED and like ICU is super different, and they always butt head with each other and stuff like that. What is your opinion on that?
Yeah. So it can be. You do have to be able to, I guess, hold your own, so to speak. And I think that the ability to do that, it comes from a lot of, self-development and learning communication skills and learning how to keep your work at work and how to keep yourself separate and, have that time to have self-care and really build yourself up and have, a, a good basis for your you. So that when you do go into these situations and you have somebody that's in your face, that's yelling, that's telling you, you're not doing things right or you're not doing them fast enough, that you can back up and really be able to look at that objectively, because not everybody teaches kindly, and some experiences don't really warrant the chance to sit down and go through things slowly and learning on the fly. And learning under stress is difficult, but that's where you come again to having a good peer support and being able to circle back and ask for debriefs. That's really been promoted as a culture even when I was in nursing school, is coming back and say, hey, can we debrief that? Like, let's talk about that. ICU, from my understanding, I've never actually worked up there, but it's a lot the same. There is the expectation that you show up, you hit the ground running, you have this solid knowledge, but there also really is this understanding that nobody's going to know everything, and that if you don't understand how to do something, you don't guess, you ask. If you're not sure how to, adjust the vent or the ECMO, don't just poke at it and guess, ask. It's, you're going to have people there that are experts. You're going to have people that are unit champions of different things. And those people are there to be asked questions of, for a while I was what they were calling a mental health champion. And so when people had questions about restraint charting or how to medicate, or if a certain medication was appropriate for their patient, or they were nervous about the amount of medication they were giving a patient. I was able to answer a lot of those questions because it was something that I had had a ton of experience with. And I was more than happy to answer those questions, to walk people through it, because at the end of the day, it's the patient that matters. And yeah, there's a lot of egos, and that's very real. But that can also mean that there's a lot of learning opportunity as well. Did that answer your question?
Yes, absolutely. Thank you.
Yeah.
I have a question.
Yeah.
Hi. Okay. Thanks for doing this. This is really interesting. My question was kind of along the lines of patients who have been kind of more than a handful. Of course, like my background is in like OR nursing. I worked in a level 2 OR, where people are often like soon to be intubated and sedated, so they're usually not swinging. But obviously in the ED, that's a different situation, and people can come in quite aggressive and hostile. How do you cope with that, and what are some strategies that you have for that?
Well, I'd like to say we just sedate and intubate them, but that's not, nor is that appropriate in most situations. There's a huge range of why somebody might be coming in aggressive, and I think the most important thing is safety. At the end of the day, you want to walk home in the same shape that you were in when you walked in the door. But you also want to keep the patient safe and keep the patient from hurting themselves or anybody else. So sometimes those safety interventions have to take place before you can really do any troubleshooting as to why they're upset. Sometimes it doesn't escalate quite so quickly, and you can figure it out fairly rapidly, or they come in and they're known to the ER to maybe be somebody with a mental health problem or a substance abuse problem, or both. And you can be ready with appropriate interventions, meaning like restraints and medication and security. And, because sometimes, obviously de-escalation is always the preferred option. If you can de-escalate somebody versus restraining them, if you can get them to take oral medication versus IM medication, obviously that's ideal. And it's going to depend, one, on the acuity of your unit, and two, on the acuity of the patient as to how well that's going to work. Some people, that's just not going to work. People also may come in really upset because they're really altered. For example, I had a guy come in to triage the other morning that was kind of yelling and screaming, and I looked through his chart really fast because something just seemed odd about it. And he had recently been admitted for hyponatremia. And so that's where my mind went, was this guy needs an IV. He needs to have his sodium corrected, and he's probably going to need to be medicated in order for us to be able to get that far. I should also probably take him to a bed where I can then bring his family member back. And so being able to see that, okay, this guy isn't just upset, there's something else going on. And sometimes it's not that obvious. In that case, I was lucky and it was pretty obvious what was happening. People may be altered because of dementia, or they may have an injury that they're not able to tell you about. So it's a lot of troubleshooting. It's a lot of, and when you start out, it's kind of a lot of guess and check. So, and then there's the patients that escalate. They come in perfectly fine and they escalate while they're there. And it's kind of, why did they escalate? Are they tired of waiting? Are they in pain? Did they come in high and now they're not high anymore and now they're mad? Is there something else going on? Are they about to seize? So there's difficult patients will always be there, and there's probably as many reasons for patients being difficult as there are difficult patients. That is one reason nurses do leave the ER to go to something like interventional radiology or PACU or cath lab, is because of that drain on yourself while you're working.
Thank you.
Okay, I'm interested in the blood and guts. So do you have a most memorable story?
So when I saw your email about most memorable story, it's kind of like you asked for a story and then I got it's like somebody asking you for your favorite song and all of a sudden you've never heard a song before. But there are many gross things that I've seen. The coolest thing I have ever seen was an open chest. And that was from a gunshot wound, because that's usually how that happens. They had opened her chest already by the time I was in there, so I didn't actually get to see the chest being opened. But just having seeing a human open and seeing multiple surgeons with their hands in there they were trying to suture her aorta is what they were trying to do, because the bullet had ricocheted through her rib cage and severed the aorta. Unfortunately, that particular effort was unsuccessful, but there have been successful interventions of that kind. While I've been in the ER, I've never been fortunate or unfortunate enough to have them as my patients, but it does happen, and it's kind of cool. There was another really cool one was I got to see an evacuation of a subdural. We couldn't get the person up to the OR or the ICU. There wasn't space to get them up there. So neurosurgery came down and evacuated the subdural hematoma in the trauma bay. So they peel the skin back, they drill into the skull, and they take the hematoma out. And then obviously there's really close monitoring that has to happen to make sure that they're not continuing to bleed into that space. But that's subdurals are scary, but they're also very fascinating because I don't think I've ever seen two that are the same. Until you get to, you see and I've seen two where it was, the person was actually herniating. One of them, again, as soon as we saw the herniation, they were able to go straight to the OR, and that person ended up surviving, which is absolutely incredible. Usually impending herniation there's nothing you can do, and that particular individual was lucky enough to go to the OR and just being a part of that and seeing that on the scan, and your heart drops into your feet because you got to move. But it's being in a place where you can do some kind of an intervention like that is there's no other job where you could do that. More blood and guts. I had a guy the other night who had managed to get a piece of wood through and through the back of his calf, and then yanked it back out, refused to stay for surgery, refused to hold still. So I'm laying on this guy. I'm laying on his bottom half. His friend's laying on his top half. And the doc picks up his entire skin and has to irrigate all the wood out. So she put probably 2 liters through the back of his calf. And, putting the lidocaine in, he was all over the place. So there wasn't even coverage, on the lidocaine. It'd be like if you were trying to talk while the dentist was trying to numb your mouth, it wouldn't work that well.
And they didn't sedate that guy?
He didn't want to. He had the option to stay for a surgical consult, and he was incredibly intoxicated and declined, which is absolutely his right to do so. And then you consider like the medical necessity of sedating somebody, and the dangers of sedating somebody that's that drunk. He could have ended up, we could have ended up in a really in a much bigger problem. We could have ended up with him like getting intubated and then vomiting into an ET tube and then aspirating. So we could have ended up with a whole sequelae of problems. So, he promised us he could hold still. He went back on that promise, which people do. Don't believe anyone when they tell you they can hold still. At least 50% of the time they're not correct about that. And so yeah, and so she had all of his skin lifted up and she was irrigating it, and this more than once I've had my face right here to where a doc is suturing and just kind of hoping that they don't hit me in the face with the needle that they've got in, Sir Drunk Man. But then the advantage to that is, Claire, like you've probably seen in the OR, you get like an opportunity for a really experienced doc or surgeon to tell you why they're doing something a certain way, and you learn about an intervention that really is outside your scope of practice, but now you have this significantly better understanding of why you would stitch a certain wound a certain way, or
totally.
And I think that kind of thing is invaluable. I think and that's what I say, there's always something new to learn. I've seen a few times where someone has cut an artery. I had a kid scalp himself in a car wreck, and by kid, I mean, I think he was like 18, and he had an arterial bleed. And so getting to see the doc tie off, he had a few arterial bleeds. And so I had, my fingers on all of them, because if you can't just put regular pressure on a wound like you would with a venous bleed or a capillary bleed, straight pressure would work really well, but you have to actually find where the bleeds are and put direct, like very direct pressure for quite a long amount of time to get those to stop. And if they don't, then your option is to have the doc come in, and they'll use like the dissolvable sutures or like the gut sutures, and they'll just tie off they'll just tie a knot on the end of the artery, just like just like you would tie off the end of like a hose, and it usually works really well. And I don't know that I have the dexterity to do that, but it's really fun to see the docs do it.
What's your favorite situation, like when someone walks in and you're like, ooh, I want to take care of that patient? Like, what's your favorite thing to see?
Well, pre-COVID, it was respiratory distress. Now, not so much, because just the amount of PPE that you have to wear in the respiratory distress rooms, because everybody's COVID until proven otherwise, right? And so that can that makes it a little bit just like harder to move. COVID changes everything. Yeah. Yeah. And let's see, what else do I like? I like fractures. I like being able to I like them when I'm not in charge of the charting for the conscious sedation, when I actually get to help reset the fracture or put the splint on, or, put somebody in, Buck's traction for a femur fracture that can't immediately go to the OR. I think those are, and I think it's because it's like sutures. It's like they're better. Like you actually made them better. And like same with respiratory distress, they come in and they're struggling and you get them either intubated or on BiPAP and, they're better. You made them better. Obviously intubating can lead to its own set of problems, but that's one thing that I wish I had understood better in nursing school, or at least going through like orientation for the ER the first time, is what it meant to do rapid sequence intubation and what all you have to know and do to make that work successfully. Because once you do it, it's second nature, but the first time you're doing it at all, you're like, wait, was I supposed to know how to do this? Like, do you push the paralytic first or the sedative first? It's very nice to push the sedative before the paralytic. It's amazing how easy it is to mess that up. When you confirmed the doses, did you check in your head to make sure that those doses made sense for how big that patient was? Even experienced docs can make huge errors, but I worked with a lot of resident docs in DC, and they would get things backwards just as much or more than I would, and you have to. And then if you are unsure for some reason, how do you find the answer quickly? And I think that's something that has been with the EHR has been absolutely amazing. You can look up almost anything instantly. The things that you can't, I have little badge buddies for. And the badge buddies that I have changed over time. I used to have badge buddies for like the difference between a STEMI and an NSTEMI and a code stroke. And now I know all that, but I have badge buddies for like starting drip rates and like acute respiratory distress and ventilator management that we got from education when COVID started, and we thought that nurses were going to be having to do all this vent management. And I have pediatric vital signs because I know them, and for the life of me, and a sick kid comes in, I have to look again every single time. I have an ESI one, or I used to. Something happened to it, but for triaging, like what is, like, am I appropriately differentiating between a level 2 and a level 3? And if there's 3 people in the lobby and 4 open beds, maybe it doesn't really matter. But if there's 20 people in the lobby and 0 open beds, like, that matters. And so having every resource to be able to make the right decision is great. And
is there something you wish your ICU counterparts knew? I work as a tech in an ICU, so.
This goes for ICU and med surg, and it's like, we're not giving you this. Well, we're not giving you this patient so that you can do our work for us. We're giving you this patient because there's another one coming in. or in especially in the case of ICU, depending on what the patient's there for, it's like sometimes I'm giving you this patient because I don't know what else to do. Like this is your area of expertise. Like I don't, like I've fixed what I can fix. Like now it's your turn. Um, or like maybe I could fix this person if they were my only patient, but I have 3 other patients and I cannot give this person the time that you can give them, you know? And
That makes total sense. Thank you.
and I would be lying if I said it always happened in the elevator. um, that said, it is nice to tidy up your patients the best you can before you get them out of the ER. I know there's Gustav, like you were talking about, there's that tension between ER and ICU, and always the accusation that the other side isn't doing the most that they can. And really there's a lot of little things that you can do before you take a patient upstairs, to kind of just demonstrate that you really did do your best, you really did do what you could. And you don't always have time, but the days that you do have time, it's really nice to clean them, put them on clean sheets, make sure there's not a BM in the bed, label your lines. It's when you have time to do that, it's very considerate to do that. And I think that can go a long way in bridging that gap. And that to say, I had a guy one day who was in a first degree heart block, kept bradying down into the 30s, and both of our code cards were in use. He got a ready bed upstairs, and I called him and I said report, like, I said my report is get ready, like get ready, like I've got IVs in him, and that's about as good as you're gonna get. It was shift change. I was taking over from a nurse that really hadn't been able to get things together maybe as well as they could have, and the ER was so crowded. I had to move 6 gurneys just to get this guy out and into the hallway, and I'm doing this at full speed with and I'm basically running down, and he was of course not in the ICU that was right above us, he was in this ICU. And so and then the monitor that I have him on is about to die. And so I'm running down the hallway. I've got like 5 family members running after me. And that was was it a full moon? Probably.
That's crazy. You have 2 core cards in use and you have that train wreck. That's wow.
Yeah. And so, that's one of those where you get them to the floor and you're like, I'm sorry, please fix it. And then hopefully then the next time I bring them a patient, I can bring them one that's all nicely packaged up. But that is where it's, and I did have some good friends on that unit, and it was nice for to be able to see them and like, okay, like I know you're going to take good care of this person. Like I know I can walk away and everything's going to be okay. I know that I can reassure the family that everything's going to be done, and everything's going to be done. Yeah, they can curse my name the rest of the shift, but at the end of the day, they're going to take perfect care of that patient. And so that having that kind of relationship is priceless, and you don't always get that. And but when you have it, it's very much worth valuing. I do more things, more collaborative things together. I guess they used to have ER ICU softball games and stuff like that. That would be nice to get that camaraderie. Meg, you had a question?
Yeah, I was going to ask if you've had anything remarkably entertaining, like crippling abdominal pain, and it turns out to just be gas or something like that.
Yes, That exact thing, yes. Yeah, sometimes we're not kidding when we say it turns out they were full of shit. I'm sorry, maybe I'm not supposed to swear on this thing. I'm being recorded. It's terrible. Full of stool.
I also heard a lot of like chest pain that ended up being like a heartburn.
Yeah, so you always assume that it's cardiac. Chest pain, you assume it's cardiac until proven otherwise. The downside to that is that it means that you usually give aspirin, which means if it is heartburn, you just made it way worse. So frequently it's worthwhile taking a look at the patient's history, at their EKG, maybe waiting for a troponin level to result before you give the aspirin, trying a GI cocktail in the meantime, which by GI cocktail, I mean, there's a mix of like viscous lidocaine and Maalox. Sometimes it comes pre-mixed, which is super nice. It tastes terrible, so I hear, but it seems to work pretty well. And then if they get better immediately, you can start to decrease your concern that it's a cardiac issue. But things like chest pain or trouble breathing, you treat it like it's something bad until you prove that it's not. But as far as entertaining scenarios, yes, daily. And sometimes they're truly hilarious, and sometimes they're truly tragic. And I think I would be doing you all a disservice if I didn't actually touch on some of the true tragedy that can happen in the ER. And there is no way to truly prepare yourself for that. But kind of like I talked about earlier with, maybe some of like the cutthroat behaviors or the horizontal violence that can happen, is really having a place and a space, whether that's just a space inside your head, whether it's a physical space, whether it's another person, to really step back and be able to be yourself and have those real conversations and address things. Sometimes everybody deals with things differently, and it's very important to be able to find a way to go home at night and still be you, because there have been many books and articles and seminars on the topic of secondary trauma and how that affects caregivers and caregiver burnout, and really what can amount to a true moral injury in caregivers, not just burnout. There's a huge difference between going home and saying go home and take a bubble bath and let's have this conversation about what went wrong and how you feel, and it's okay to feel crappy, and being able to keep an eye on your coworkers, on your buddies, and having at least one person that you can talk with. It becomes very important. And as I'm sure working in the ICU or the OR, you have those tragedies or those unexpected outcomes that sometimes can be a little bit difficult to process in the moment. And most days I go to work and I come home and that was a day. It was chaos, it was fun, it was chill, it was this. And there are those days when you come home and you're like, wow, that was heavy. We should all just be assigned therapists when we graduate. That wouldn't hurt. And I definitely think that culture is shifting to be able to encourage people to access those resources. And I know most of the hospitals that I've worked at, there is way to get no cost counseling. And I think that I have somebody that I've talked to, over the years, just like, hey, something happened. Can I talk to you for an hour? And, it makes a huge difference in just, getting and having the tools to process that. And that goes for any type of nursing. And because there's really not another job that has there are very few other jobs, and most of them are medical jobs that have that level of emotional investment in your day-to-day work. The other thing I wanted to talk to you guys about was certifications. I know you guys probably all have your BLS. You probably have had, and Sarah, I think you told me you guys have the opportunity to get your ACLS. There's always more education that you can do, and certifications to show that you've done the work, that you've learned the content, that you can push through it. And some of them you have to have a certain amount of time to sit for. I think the CEN, you have to have 2 years. TCRN, you have to have a certain number of trauma hours to sit for. CPEN, which is certified pediatric emergency nursing, you don't have to have hours to sit for. You just have to learn the content. Actually, maybe you do have to have hours. Anyway, but it's very worthwhile. And those, even if you don't take the exam, those books can be very, very helpful in learning things. And just getting, and I'm sure the last thing that any of you guys are going to want to do after you take the NCLEX is sit down and take another standardized test. I get that. I do. But once you've kind of got your feet under you and you're thinking about specializing, those, even just joining those professional societies, taking advantage of the new grad rates, and the amount of information that you get and the amount of community that you can get is amazing. Because then you're learning what you want to learn. You're learning your job, and maybe you start down the path as an ER nurse, and you're like, this is great, but I can't do this full time. There are a ton of ways to still be involved in trauma and critical care that don't involve floor nursing full time. There's all kinds of like trauma data management programs. There's obviously informatics opportunities to make the EHR better within your unit. There's research opportunities if you're interested in more school. So there's always ways to, if this is your passion, but 36 hours a week, on a night shift or a rotating shift or a weird shift isn't working for you. That doesn't mean you have to abandon this line of work. There's all kinds of things that you can do. It looks like we're at time. Were there any, I know we started a little bit late, Meg. I don't know if you wanted to go over a little bit and give a chance for some last questions.
If anyone has any that they really are wanting to ask, then yeah, if you have time, Amelia, that would be great. Otherwise, I do want to be respectful of everyone's time. So
yeah.
Does anyone else have anything that they want to ask, want to address? Okay, Amelia.
Well, I'll put my email address in the chat here. If you guys want to reach out with any more questions, you're more than welcome to. And if I can't answer your question, or if you have a really specific thing that you want to know more about, I probably know somebody that can, even if I can't answer it. So
Thank you so much. We really appreciate this. We will be in contact about a thank you gift for you.
Thank you. Thank you
my
for-
pleasure. It's
Thank
great
you so
talking to
much.
you guys. Yeah.
Thank you, everybody. Have a wonderful rest of your day.
Thank you.